Hi everyone, my name is Pavel Antipovich. I'm a Canadian cardiac electrophysiologist, and today we'll be discussing an approach to wide complex tachycardia diagnosis. Now, the approach that I will introduce you to is used by cardiac arrhythmia specialists, and it focuses on understanding the arrhythmia mechanisms. So this is the approach that's taught to cardiovascular trainees when they rotate through their EP rotation. Traditionally, wide complex tachycardia diagnosis is taught using algorithms, one of the most popular being the Brugada algorithm. And I learned the Brugada algorithm from my cardiology exam, but I don't actually remember much about it. These algorithms are hard to remember and often require you to make measurements and memorize numbers, which are hard to do, especially if somebody hands you an ECG to interpret. I'm going to show you an approach that doesn't require any measuring and is just application of basic arrhythmia principles. The approach we'll take is the same approach used for any internal medicine problem. We identify the problem, which in this case is a wide complex tachycardia, and we will explore what makes the QRS wide and what makes it narrow. We'll create a differential diagnosis list and use features of the tracing to narrow the differential diagnosis. Let's briefly review the conduction system of the heart. There's the SA node that sets the ambient atrial rhythm. There's the AV node that controls access of the electrical signals to the ventricles. There's the bundle of His, which is a common conduction fiber that carries the signal down to the bundles. And there's the right bundle and the left bundle. And the right bundle inserts into the apical septum of the right ventricle. And the left bundle activates the septum and divides into the left anterior fascicle and left posterior fascicle, which insert around the area of the papillary muscles. These little arrows represent Purkinje fibers that quickly carry signals from the bundles to the muscle fibers, and they're very important to having the QRS narrow. For the QRS to be narrow, activation of the ventricles has to happen simultaneously. For instance, if there is a delay in the conduction of one of the bundles, for example, a left bundle branch, or there is conduction block in the left bundle, the signals travel down the functioning bundle, activate the chamber, and then they have to travel across the septum via cell-to-cell fashion to activate the other chamber. And this results in dysynchronous activation of the ventricles and slow conduction, and this prolongs the QRS, in this case, a left bundle branch block pattern. There are several reasons why the ventricles are not activated synchronously in a tachycardia, and cell-to-cell conduction takes place. These are the differentials for wide complex tachycardia. Whenever a trainee encounters a wide complex tachycardia, it always looks good to say, this is a wide complex tachycardia, which has the following 5 differential diagnoses: ventricular tachycardia, SVT with aberrancy, pre-excitation, pacing, and artifact. Let's look at each one of these in more detail. Artifact is usually fairly easy to recognize, but it can sometimes be tricky. It's important to examine the tracing for an ambient rhythm within the noise, which is fairly diagnostic. In this case, I can see the ambient rhythm marching through the tracing. There's often a wandering baseline, unusually short, what we call non-physiologic intervals. It's also important to scan other leads that are recorded simultaneously. As you can see, high-frequency signals are seen in lead 2, but lead 3, which is taken simultaneously, shows sinus rhythm. This is an example of a tracing with noise that was marked as atrial flutter. As you can see, we can see these high-frequency signals in some of the precordial leads, but when you look at the other leads, it's clear that there's QRSs that are marching right through this noise. The second item on our differential is pacing. Pacing is often easy to spot because there is pacing artifact or pacing spikes. There are a number of reasons why a pacing device can pace quickly, which is a topic for another discussion. Pre-excitation is also on a differential for a wide QRS tachycardia. Slurring of the QRS in pre-excitation happens because the accessory pathway often inserts into the myocardial muscle. And when conduction happens over the accessory pathway, it very slowly activates cell-to-cell the myocardium around the insertion. This takes place until the signals simultaneously go down the AV node, activates the His-Purkinje system, which activates the rest of the ventricle within milliseconds. So pre-excitation is often a fusion between accessory pathway conduction, a slow myocardial activation, and conduction down the AV node and the his Purkinje system, which rapidly activates the rest of the ventricles. Any SVT, which is a tachycardia where the mechanism is entirely in the atria, including sinus tachycardia, atrial tachycardia, AV NRT, flutter, etc., can conduct down the accessory pathway and fuse down the node, or conduct fully down accessory pathway and become fully pre-excited. So this differential diagnosis is very hard for trainees to exclude. With experience, you can look at the ECG and say, hey, this is not pre-excitation because it does not fit any pattern for an accessory pathway. However, the best approach for non-EP practitioners is to look at the baseline ECG in search for pre-excitation. If you see it pre-excited, the pre-excited SVT is a real possibility, keeping in mind that it is possible that pre-excitation happens only during tachycardia. Overall, this entity is fairly rare in a non-EP practice, and we can usually skip it, but keep it on the back of our minds. So in this particular example, you can see there's a sinus QRS, which is pre-excited, and when the tachycardia initiates, it produces the same pre-excited QRS that's ongoing. So this is an example of a pre-excited SVT. When we look at this patient's 12-lead ECG, there's clearly baseline pre-excitation, which raises our suspicion for the diagnosis of pre-excited SVT. To summarize, on our differential diagnosis list, we can usually exclude artifact by looking at numerous leads. We can exclude pacing by the absence of pacing artifact, and pre-excitation is highly unlikely and made even less likely if there's no baseline pre-excitation. So we are left with two main differentials, SVT with aberrancy and VT. Let's take a look at these in more detail. SVT with aberrancy is important to distinguish from VT because SVT is benign. Although SVT is symptomatic for patients, patients are generally not harmed by it, and we often discharge patients from the ER. This is very different from VT, which generally have a poor prognosis. SVT with aberrancy is any SVT mechanism from the atria that conducts down to the ventricles with a wide QRS. Recall that a wide QRS is produced if there's a problem in the conduction system of the ventricles, which is almost always a left or right bundle branch block. So when we say aberrancy, we generally mean bundle branch blocks. In this particular example, any atrial arrhythmia, which includes any sinus arrhythmias, focal atrial tachycardias, atrial flutter, AV NRT, in this patient will conduct with a right bundle branch block pattern. So it'll produce an arrhythmia that is wide QRS and looks like a right bundle branch block, as you can see in the picture on the bottom left of the slide. Because the conduction comes down to left ventricle, undergoes transeptal conduction to the right, which produces a wide QRS. The key mechanistic feature of SVT with aberrancy is that it's driven by the atria. The ventricles are just passively activated by the atria. This is unlike VT, where the ventricles are dominant and drive the atrial rhythm. Since the ventricles are driven by the atria in SVT with aberrancy, there have to be at least as many A's as there are V's, or rather as many P waves as there are QRS complexes. If there is more ventricular activations than atrial activations, then the ventricles are dominant and it's not SVT. This is the basis for AV dissociation, which we'll discuss later. The second feature is to look at the baseline ECG for baseline conduction abnormalities. Patients with SVT with aberrancy often have baseline bundle branch blocks and have a wide QRS to begin with. And when they go into SVT, the same wide QRS just becomes faster. However, it's important to note that some bundle branch blocks are rate dependent, and the patient may have a baseline QRS which is narrow, but develops a bundle branch block when the rate accelerates during SVT. The third feature is the initiation. If you see a wide complex tachycardia initiate with an early A, or a PAC, it is almost certainly SVT, because VT almost never initiates with a PAC. If you look at the example down below, we see a sinus QRS, which has a baseline right bundle branch block. And this patient's tachycardia initiates with an atrial activation with a long PR, and this right bundle branch block accelerates and becomes wide complex tachycardia. So this patient's wide complex tachycardia initiates with an A, and the patient has a baseline right bundle branch block, which are the two reasons why this is SVT with aberrancy. Now let's talk about VT. VT should be taken very seriously because patients with VT generally have a worse prognosis. These are patients that require additional investigations and treatment. VT is any tachycardia that is driven entirely by the ventricles. There is unhealthy muscle in the ventricles which causes acceleration of the rhythm. During each VT cycle, there's activation and conduction up the conduction system, up the AV node to the atria. This creates a retroconducted P wave. However, some patients may not have what we call VA conduction, and there's VA block somewhere in the AV node or in the tissues below the AV node. And the VT signals cannot make it up the AV node and cannot drive the atria. These patients may have sinus rhythm in the atria and VT in the ventricles, and we call that classic AV dissociation. About half of the patients with VT have VA conduction, and about half the patients do not have any VA conduction and would demonstrate AV dissociation. Now, the key feature of VT, remember that it's driven entirely by the ventricles. There will be at least as many V's as there are A's, or at least as many QRS's as there are P waves. And oftentimes there are more V's than A's. In those who have no VA conduction, there may be sinus rhythm in the atria, and these demonstrate AV dissociation. This is an example of a classic wide complex tachycardia which has the usual differential diagnosis of VT, SVT with aberrancy, pre-excitation, pacing, and artifact. And I always make this statement every time I'm evaluating a wide complex tachycardia on a formal basis. We can exclude pacing because I do not see any pacing artifact. We can exclude noise because this is a very clean tracing. And it is not a pattern for a classic pre-excitation, although we don't have a baseline ECG. This is a classic right bundle branch block pattern, which makes me think of an SVT with a right bundle branch block. However, we note there are P waves that are associated with the QRSs in a one-to-one fashion. Since they're associated, this is not usually helpful. It could be VT or SVT that's one-to-one. However, we note that there are P waves missing after some cycles. How could this happen? Some VT activations are blocking in the node and are not making it up to the atria. In other words, there are more V's than there are A's. So the ventricles are driving the atria. So the diagnosis has to be VT. Now that we know the mechanisms for VT and SVT with aberrancy, let's discuss strategy. Before we begin, it's important to note that 80% of wide complex tachycardia will be VT. If the patient has structural heart disease or reduced EF for any reason on the echocardiogram, the likelihood of VT goes up to 90%. It's important to note that there has to be a very compelling evidence of otherwise to dissuade me from the diagnosis of VT, especially if the patient has structural or ischemic heart disease. Also, treatments for VT, such as antiarrhythmics and cardioversion, generally work for SVT and VT, although they're a bit aggressive for SVT. However, treatments for SVT, such as calcium channel blockers and beta blockers, can significantly harm a patient with VT. So it's always safe to presume VT unless you have strong suspicion otherwise. This concludes part 1 of this discussion. Now in part 2, we will summarize all of these concepts and formulate a strategy for distinguishing between VT and SVT with aberrancy, and we'll present a couple of tools to help you achieve this.